Hello, and welcome to this Clinical Care Options podcast episode. This episode is a featured component of an educational program titled A New Way to Low, Targeting Residual Inflammatory Risk in ASCVD and CKD. I'm your host, Kim Neely, and today I'm excited to be joined by amazing faculty experts. Dr. Erin Michos is a professor of medicine, director of women's cardiovascular health, and associate director of preventive cardiology at Johns Hopkins University School of Medicine. We also have with us Dr. Mark Sarnak, professor of medicine at Tufts University School of Medicine and chief of the Division of Nephrology at Tufts Medical Center. To find more activities on targeting residual inflammatory risk in ASCVD and CKD, including a CME certified text module with animated video and faculty voice audio clips, clinical thought commentaries, and more, visit clinicaloptions.com or visit the link in the show notes. Now I'm excited to hand it over to our guests.
Hi, welcome back. We've been talking about inflammation on our first podcast, and we're going to continue with this theme. As we had alluded to before, unfortunately, cardiovascular events still occur in statin-treated patients. We have known for decades that inflammation is independently associated with future atherosclerotic cardiovascular disease risk, even when accounting for lipids. The Women's Health Study and the Physicians' Health Study, which were both published back in the year of 2000, over 20 years ago, showed that inflammatory markers such as high sensitivity C-reactive protein, interleukin-6, and interleukin-1 beta were highly associated with incident atherosclerotic cardiovascular risk. And then the Air Force Texas Coronary Atherosclerosis Prevention Study, one of the early primary prevention statin trials, suggested that patients with evidence of low-grade inflammation might be at risk, even when their LDL is controlled with statin therapy. And then this was followed by the Jupiter trial, which was a pretty landmark trial evaluating rosuvastatin in patients who did not have cardiovascular disease and whose cholesterol was relatively well controlled with an LDL under 130, but they had inflammation with a CRP greater than 2, showing substantial cardiovascular benefit with rosuvastatin. But notably, patients treated with rosuvastatin who achieved a dual target on therapy, who achieved both an LDL level less than 70 milligrams per deciliter and a CRP level less than 2 milligrams per liter, they had the lowest cardiovascular event rate. There was a 65% reduction in vascular events in patients with rosuvastatin who hit both of those targets versus only a 33% reduction in rosuvastatin-treated patients who achieved one or neither of those targets compared to the placebo-treated patients. And then furthermore, a recent sort of analysis of over 31,000 statin-treated patients with cardiovascular disease or high risk for CVD. These were participants of 3 major trials of non-statin therapy of the prominent REDUCE-IT and STRENGTH trials, showed that residual inflammatory risk as measured by C-reactive protein was a more powerful determinant of who would have a subsequent cardiovascular death than residual cholesterol risk as assessed by LDL cholesterol in these statin-treated patients. And so while these data must not be construed to diminish the proven and crucial role of adjunctive lipid-lowering therapy, so we still want to achieve those lipid targets, these data do suggest that targeting LDL cholesterol alone is unlikely to completely reduce atherosclerotic risk, and that inflammatory pathways have yet to be fully explored to reduce fatal and non-fatal cardiovascular events. So I'm going to turn it over now to Dr. Sarnak to talk about patients with kidney disease and the role of lipid-lowering therapy and residual inflammation.
Yeah, so patients with kidney disease have significant dyslipidemia, not always hyperlipidemia. In fact, as the kidney function gets worse, and particularly on dialysis patients, cholesterol levels sometimes drop, presumably due to malnutrition and things like this. In kidney disease, we don't have as big trials as they are in the cardiovascular literature, but the SHARP trial in 2011, for the first time, demonstrated a benefit of simvastatin and ezetimibe in patients with CKD for reduction of cardiovascular disease. So this was one of our first positive trials that was focused on dialysis patients and patients with CKD and showed a benefit. I think it's pretty clear that there's still a very high residual risk of cardiovascular disease, even in people who are treated with statins. And in fact, in CKD, there's some studies, for example, from CANTOS that show that inflammatory markers are more powerful risk factors for cardiovascular outcomes than are levels of LDL cholesterol. So we recognize that there's high residual risk in patients with CKD, and we need to find new interventions to reduce this cardiovascular risk. The KDIGO guidelines recommend that all patients with CKD, whether you have known coronary disease or not, if you're above the age of 50, because we recognize this is a very high-risk population, everyone should be put on a statin, irrespective of anything else. If you have diabetes, you're going to probably do it at even a younger age. There's recommendations to do it at even younger age. I think in dialysis patients, which is our extreme group of patients with CKD, we don't have the trials that show benefits of statins, but the patients still have very high residual cardiovascular risk, and inflammatory markers are very high. So finding ways to reduce cardiovascular events in the dialysis patients is also of critical importance.
Great. So yes, these events are still occurring in statin-treated patients, although statins are first-line therapy for primary and secondary prevention of patients with or at risk for cardiovascular disease, and particularly patients with kidney disease. Patients with kidney disease are actually more likely to die of a cardiovascular cause than to go on to progress to end-stage kidney disease. And so statins are still endorsed as first-line therapy in patients with CKD for reduction of cardiovascular risk. So among this residual risk, there can be residual cholesterol risk. So sometimes we need to get the cholesterol even lower in some of our patients. There can be residual risk related to lipoprotein little a, which also can be, although strongly genetically determined, it can also increase in kidney disease. There can be residual risk related to triglyceride-rich lipoproteins, residual thrombotic risk, residual cardiometabolic risk, which we are addressing often with these new class of therapies like SGLT2 inhibitors and GLP-1 receptor agonists, and then this residual inflammatory risk that we've been discussing on this program. So patients often need a tailored approach to figure out sort of what aspect of residual risk is the primary driver for them so that we can do targeted intervention. So in terms of inflammatory risk, just to kind of go back to pathways, because when we're going to be talking about these novel anti-inflammatory targets on our next podcast to sort of understand these inflammatory cascades. So in the first podcast, we introduced the NLRP3 inflammasome. So again, this is a multi-protein complex that plays a pivotal role in regulating the innate immune system and inflammatory signal. And this NLRP3 inflammasome is a protein that can be on a variety of cells, but including neutrophils, macrophages, lymphocytes, and epithelial cells. So the NLRP3 inflammasome activates caspase-1, which then initiates the processing and release of the pro-inflammatory cytokines interleukin-1 beta and interleukin-18. And these cytokines then are released to activate a variety of inflammatory cells. They produce IL-6, interleukin-6, which stimulates the production of C-reactive protein from the liver and amplifies the inflammatory cascade within the vessel wall. So in terms of our targets, we're going to talk about colchicine in our next podcast, which has a lot of different mechanisms. We don't fully even understand all of its mechanisms, but one of its mechanisms is that it does interfere with this NLRP3 inflammasome. And then we're going to also talk next about canakinumab in the CANTOS trial. That was an interleukin-1 beta antagonist, a monoclonal antibody targeting interleukin-1 beta. But we also then can go sort of downstream, sort of more targeting and thinking about inhibiting interleukin-6. Interleukin-6 is a pro-inflammatory cytokine. High interleukin-6 concentrations are associated with endothelial dysfunction, atherogenesis, acute plaque rupture, and increased risk of myocardial infarction. And this is becoming a target of therapy. And as we discussed earlier, plasma levels of both interleukin-6 and CRP predict cardiovascular risk, actually with a magnitude of effect greater than LDL cholesterol. We tend to measure CRP more as a biomarker because it's much more stable of a biomarker to measure and much longer half-life than interleukin-6, but interleukin-6 levels do predict risk. And while I mentioned earlier that CRP is thought not to be causally related, but just a good integrator, a marker of all this inflammatory risk, in contrast, Mendelian randomization studies have indicated that genetic variants in interleukin-6 receptor signaling pathway are associated with lifelong coronary heart disease, suggesting that interleukin-6 is likely causal for atherosclerotic progression. And both GWAS studies really affirmed a role of interleukin signaling for many types of atherosclerosis, including MI and PAD and aneurysms. And so that makes it a very attractive target. And one of the agents we'll be talking about next, ziltivekimab, is a monoclonal antibody targeting interleukin-6. Dr. Sarnak, if you have any comments specifically about some of these inflammatory markers, or specifically, where in the inflammatory pathway, we could be targeting to reduce some of this residual risk.
Yeah, we have some small trials suggesting that at least in dialysis patients, IL-6 inhibitors may reduce inflammatory markers. And we're now moving towards larger trials also in the extremes of the dialysis patients, targeting some of these mechanisms, recognizing that in patients with kidney disease, risks of all interventions increase. And there's going to be a balance between decreasing cardiovascular risk and potentially some higher side effects from these medicines. So obviously the trials are going to be critical in patients with CKD. I think as you get to the more advanced stages of CKD, risks and benefits kind of change. In the earlier stages of CKD, the results are probably going to be very similar to the general population. As CKD progresses, I think you really need the trials to assess risks and benefits.
Okay, great. So just to recap, we've discussed how inflammation is causal in the atherothrombosis pathogenesis and a new target of therapy, and both diagnosis and management of residual cardiovascular risk factors, such as residual inflammatory risk, is really crucial for optimizing ASCVD prevention. And one size likely doesn't fit all. And so we really need to tailor our prevention prescription using a precision medicine approach, after statin and lifestyle intervention, which are really the foundation. And these ongoing studies, which we'll talk about in our next podcast, will determine whether interleukin-6 targeted inhibition can reduce cardiovascular outcomes in patients with cardiovascular disease and CKD. So I look forward to next taking a deeper dive into these emerging anti-inflammatory agents in more detail.
Thank you so much to Dr. Michos and Dr. Sarnak for joining us for this very important discussion about addressing residual inflammatory risk in patients with ASCVD and CKD to improve outcomes. And thank you for listening. As a reminder, visit the episode notes or clinicaloptions.com to find more educational activities.